dying from pregnancy-related complications in America than in any other developed country in the world. And African American women are the most at risk.
Racism, it acts both explicitly and implicitly.
Some hospitals aren't prepared for maternal emergencies, and patients say they're not being listened to. Here in New York, The Square starts now. Welcome to Times Square. I'm Sally Ihart. On this show, we'll be talking about the issue of maternal mortality in America. And we want to hear your thoughts. You can send us your questions and comments on Twitter and Facebook at TRT World and be part of the conversation. The maternal death rate in America is on the rise. The US spends more money on healthcare than any other country, but more than 2 women die during childbirth every day. And pregnancy-related complications are disproportionately affecting African American women. So why is the death rate so high in America, and what can be done about the problem? With me on today's show are Denise Bowles. She's a doula who works with pregnant women and new mothers in New York City, and Dr. Keisha Gaither. She's the Director of Perinatal Services at New York City Health and Hospitals, Lincoln in the Bronx. Welcome to you both.
Thank you for having us.
Now, Denise, let's start with you. Can you just tell us exactly what a doula is and what kind of services you provide for a pregnant woman in her childbirth?
Sure. A doula is a person that provides emotional, physical, spiritual, and resource support to the mother who's giving birth, the person who's giving birth, as well as their families.
Why might a woman need that?
A woman might need that for advocacy. They might need it for enhanced services and resources to be connected within their community. They might be a single mom. They might just want that extra support in the birth room because they really feel that they may not be properly heard, or they may not really be in the know of all the intricacies of birth.
So Dr. Gaither, let's look at some broader national statistics here. Women today are 50% more likely to die in childbirth or pre-birth or postpartum than their mothers were 50 odd years ago. Why is it that, given modern medicine today, we're seeing an increase in maternal mortality rates rather than a decrease?
When you look at what's happening today compared to our foremothers, number one, there's a lot more women electing to wait until they become pregnant, thus increasing the morbidity that's associated with age-related diseases such as diabetes, such as hypertension. So they're going into pregnancy with issues already. Secondly, you have a lot of women who are electing to have IVF and assisted reproductive technologies, having multiples, so that increases certainly the cesarean section rate and all those things that go along with that.
Let's just pause the discussion for a moment and look at some broader statistics here. So I'll point your attention to the screen. Approximately 700 women die each year from pregnancy-related complications. African American women are 3 times more likely to die from pregnancy-related causes than white women, and 60% of all pregnancy-related deaths are preventable. I mean, that's quite extraordinary there, especially given the fact that African American women are up to 4 times more likely to have this sort of response to childbirth. And that seems irrespective of age, education, socioeconomic background. What about some of the diseases like preeclampsia, which are more prone in African American women, diabetes, cardiovascular issues? Can you talk to us a little bit about more of those concerns?
Absolutely. As well? There's a high propensity of obesity in the African American community. Obesity really sets forth a complex series of interconnected issues. There's an increased risk of inflammation. There's an increased risk of you developing diabetes. There's an increased risk of you having hypertensive disorders as well as heart problems. Certainly when I was training, I did not see the cardiovascular issues that I see now. But again, I also did not see women who are coming in who are 3, 4, 5, 6, and 700 pounds either, which is what I see now a lot.
The root causes behind some of these statistics are often misunderstood. A lot of deaths occur pre-birth and also in the postpartum period. Can you give us a little bit of a flavour about why that is?
Today's environment really does not support a healthy pregnancy. We have moms who are giving birth, and as soon as they give birth, they're talking about when they have to go back to work, or they have to work up until the last minute, or they're expected to work the 14, 16-hour day shift, not getting the proper rest, not getting the proper nutrition, not being fully engaged with their prenatal care provider. Everything is rushed, everything is timed. There's a clock that women are expected to beat and to do well and not to complain and, be a great mom through all of that.
It's interesting, Dr. Gaither, you've done some specific research on the role that stress plays in African American women and childbirth, given the fact that racism is deeply woven in US society. How does stress medically relate to different reproductive outcomes?
Stress, chronically, causes an increase in a hormone called cortisol, okay? That's your stress hormone. Cortisol causes a whole host of interrelated complications. For instance, high cortisol, increases inflammation in your body and decreases your immune response. When you're pregnant, your immune system already becomes depressed, simply to allow the baby to develop and say, hey, I'm here, and not have your body attack the developing fetus. So that's the first thing. When you're stressed and you already are at a loss, that increases your propensity to develop infection. So let's talk about the hypertensive portion of it. Stress with the cortisol increases how your vascular tone or your blood vessels act. High cortisol tightens those vessels. Tightened vessels equals hypertension. Hypertension increases your risk of preeclampsia.
I think that's really interesting, and it seems like quite a specific but very vital piece of research that I wonder whether is been standardised across the board in terms of doctors' training. And there has been some research stating that hospitals aren't prepared enough, doctors aren't getting enough hands-on training, that there are random protocols and not enough standardisation. And I wonder, Denise, in your experience as a doula, being inside the hospital rooms, both being a health practitioner and also an observer, what kind of variations do you see in the way that doctors and nurses approach their patients?
Here in the metropolitan area, there is a vast amount of teaching institutions. All of these hospitals are teaching institutions. So what the Black mom is not being educated on is she can spend that 9 to 10 months with her OB doing prenatal care, but when she goes into the hospital to give birth, there's a chance that that doctor may not be on call to help her deliver that baby. She will now be treated by residents. She will now be treated by strangers she's never met before. And that totally discombobulates the entire web of safety net that we have to help that mom have a good, positive outcome. For a Black mom coming in, it's even worse. It's immediately assumed she doesn't have a partner. It's immediately assumed that she's socioeconomically challenged. It's immediately assumed that she's not going to be cognizant enough to understand the instructions given to her by the medical professionals.
I do want to pause the discussion there for just a moment and show you a film about women who have their own maternal health stories. Rural America. It's fast becoming a desert for maternal health. 15% of the population live in rural areas, but only 6% of the nation's gynecologists are working there. In Salisbury, Maryland, over half the population is African American. The Centre for Disease Control says that Black women are 3 times more likely to die from maternal-related complications. This area has only one OBGYN care centre, so women here are even more vulnerable. However, they can come here to the Eastern Shore Pregnancy Centre. Misha Shockley works as a birth coach in Salisbury and volunteers at the centre.
There's only one hospital here. There's only one OB office here that services families who are having children. There's a lot of families. There's a lot of people, and they're kind of funneled in and out, in and out. They're not really being given education. They're not really being given the tools to really thrive. We see a lot of families that are in crisis. So unplanned pregnancies, which we know make up about 50% of pregnancies. We see a lot of teen moms, sometimes as young as 14 years old. A lot of domestic violence victims.
Misha came to the work she does through her own experience of childbirth. She was diagnosed with preeclampsia but was wrongfully discharged.
I knew I didn't feel comfortable with that, and I knew that I was still sick. I knew that something was still wrong, but what do you do when the hospital tells you to go home? Right away, she let me see my OB, who had been seeing me through that duration of my pregnancy, and he looked at me and he said, "You should have never been discharged from the hospital. I'm admitting you right now."
Shia Ivy was 16 when she had her first child 8 years ago. It was a traumatic delivery that scarred her. Earlier this year, she had her second baby.
They treated me as I didn't know much, because I was so young. And honestly, I really didn't know what questions to ask, being that I was young. I lost a lot of blood. I started hemorrhaging. He was face up instead of face down. I begged the doctor, please just give me a C-section because I was in labor for 27 hours. And they were like, no, you gotta do this. You have to have him naturally. We don't want to do a C-section. It's like, I didn't want to die. That's what I felt because I was losing so much blood and I was shaking.
Throughout her ordeal, she struggled to get the support that she needed from family. So this time round, she stretched herself financially to pay Misha to help her with the birth of her baby West.
I grew up in a single parent home. So, all my mom was really focused on us is just making sure that we don't become single parents or we don't grow up in poverty. So when I became pregnant, that's all she really focused on. So it wasn't no talks on what do you expect out of your pregnancy.
One of the things that Misha said was that, a lot of people assume that black women are tough and they can handle anything and they can push through it. And the way you talk about your mother and the way you were brought up and sort of not expressing emotion, is that something that you think perhaps prohibits women like yourself, black women, from reaching out for more support?
Yes, because I never knew anything about a doula. I never knew anything about extra support while pregnant. I just thought, you become pregnant, you go to the doctor and have the baby. I really do think that there is in the black community, as far as just getting through it, not asking for help.
I've come to meet Alex Richardson. Like Misha, she too suffered preeclampsia. Doctors know little about what causes preeclampsia, but it is one of the leading causes of maternal death and is 60% more common in African American women. Alex says she spent 3 days in labour with her cervix dilated at 1 centimetre.
So I decided to go ahead and get my epidural. My first epidural, the guy came in early Wednesday morning. He gave me my very first one. From what I was told after the fact, he placed the epidural in the wrong space. And he also gave me too much medicine at one time. I pretty much passed out within 10 minutes. At one point, my fiance said they had to call the crash cart, and apparently I stopped breathing. They came through and gave me my second epidural. The right side worked, the left side didn't work. So a couple hours later, they gave me my third one, and the left side worked and the right side didn't. So after that point, my kidneys started failing. I started vomiting uncontrollably, and maybe around 5 o'clock my primary doctor came in and she was like, you're gonna die if we don't get this baby out right now. Exactly.
Alex says she feels that there was some racial prejudice in the way she was treated.
I was in pain when they had my second epidural in, and she had my monitors strapped so tight they were cutting into my skin. And when I would tell her, it hurts, and she's like, oh, it's gonna hurt because you're in labor, she's pretty much just blowing it off. I asked for my very first dose of my medicine, and she was like, no, I'm not giving it to you, you need to hold off. And I'm like, you can't physically tell me no. If I'm in pain, I'm in pain. According to the other nurses, they had no idea that I had ever even asked for my first dose. Same thing when I asked for my second dose. She was just like, you need to wait, you're not dilated far enough. And I'm like, but I'm in pain. I've been in pain for 2 days. I've lasted 2 days with no medicine. I think it's time for me to get something.
So you didn't feel like you were being listened to?
No, not even the slightest bit, no.
Misha says that African American women she works with are often assumed to be alone or unmarried.
If we aren't given the tools and the education to know about certain warning signs, like for me, I didn't know that swelling and a headache could mean something serious. I wasn't educated on that. I think black women aren't heard. I don't think that we're listened to. There's this stigma that black women are strong and we can endure. And so we're going, literally, and there's several cases of it, we're going to hospitals and we're saying, hey, we don't feel good. This isn't right. What are doctors doing about it?
The rural areas of America are vulnerable. But it's in the nation's capital, Washington, D.C., that is the most dangerous place for black women to give birth. 17 of the 18 women who died from pregnancy-related causes between 2012 and 2018 were black. The DC Council unanimously passed a bill last year to study the causes of pregnancy-related deaths and ways to prevent them. Dr. Hugh Mighty is the Dean of the College of Medicine at Howard University. He says that African American women can be vulnerable for a number of reasons.
Diabetes, high blood pressure, obesity. Those are all things, again, statistically, if you look at them, they're going to be higher in that population. So they start out being somewhat predisposed to having a complication before they actually enter the pregnancy. So then they enter the pregnancy and they're carried out with them.
Do you think that there's a link to institutionalized racism?
Not necessarily. I think that there's definitely, again, a disparity in how we may address the system, but I've worked in different institutions, and I know our doors have been open to women, to come in, and we've reached out to them at all times. You can take, again, the same woman under the same condition, and they have very different outcomes, right? And so some of it has to do with, obviously, coming into a pregnancy, your early access, early diagnosis, early changes in your lifestyle that has to be there. Lacking that access, I don't think it's what I'd say is institutional racism. I'd say what we haven't done a very good job of is stressing the importance of getting into care early, or from a social perspective, the determinants of care, I think, become very important. If I don't have housing, if I don't have proper nutrition, if I don't have a job, if I don't have all those stressors, whether you're pregnant or not, right, tend to lead to poorer outcomes.
A 6-month investigation by NPR and ProRepublica found that hospitals can be highly unprepared for maternal emergencies, and that American doctors entering maternal fetal medicine were able to complete training without ever spending time in a labour delivery unit. Dr. Mighty says that while his students do spend time in real-life deliveries, this simulation room prepares them for the rare complications that could arise.
So what you'll find is we've raised the bar by, one, using more simulations, more drills, to get people familiar with how do you handle an obstetrical hemorrhage. When someone's bleeding and they're bleeding in pregnancy, they're generally bleeding a lot and you don't have a lot of time. So how you handle that means you have to be able to recognize it, act in a coordinated fashion to solve it, which leads to your other thing is that rather than having 10 different protocols around things, if we have a very basic protocol that can be expanded upon, everyone is acting in sync.
Maternal health is starting to be discussed more. In fact, it's a subject for the 2020 presidential campaign trail. Both Senators Kamala Harris and Elizabeth Warren have discussed the stark racial disparity. In 2017, 2 maternity wards closed in DC. Both were in predominantly black communities. One of them was at Providence Hospital. Nolene Jeffers was a midwife there. Most of Nolene's patients are African American women with low incomes. She says the biggest complaint is that women aren't being listened to.
Racism, it acts both explicitly and implicitly, right? So that nurse who may be providing pain medications to the white women, but not to the black woman, may be acting on what we call unconscious bias. Perhaps she might be assuming that the black woman is is medicine seeking. And perhaps she may have faulty beliefs about how black women process pain. So, and this is backed up by research. So at the crux of it is unconscious bias and the fact that it's negatively impacting black maternal health care.
The stories of the women that I've been speaking to are tragic personal experiences, but there seems to be a familiar pattern. While everyone agrees that education and access to healthcare plays a large role in reducing maternal mortality, the fundamental thing that all women want is to be heard. So, pretty powerful piece in terms of listening to those women's stories, but I wanted to pick up on you, Denise. I noticed you gasped there when you heard the doctor say that he didn't believe that institutionalised racism was a factor. Why did you gasp?
I guess because the foundation of American westernized gynecological and obstetric medicine is based off of Dr. Marion J. Sims, who's called the father of gynecology and obstetrics. And Dr. Marion J. Sims conducted his research and a lot of his procedure techniques on black female slaves without anesthesia. And that paradigm has been carried out throughout the American westernized obstetric and gynecological care up to this day, where you have black women who will go into the hospital and say, I'm in pain, and you will have that white provider say, oh, you know, I don't think you are.
What's interesting though is he's an African-American doctor, you know, and I wonder here if there's also some gender discrimination, or the fact that being a doctor, a lot of the women I spoke to said that they had great care from their doctors, but when the doctor would leave the room, it was the nurses that they had problems with. So when he actually said that, I put that to him. I said, is there a chance that you're blindsided, that you don't actually see some of the racism that goes on? What do you think, Dr. Gaither?
I think that institutional racism exists. I think that it exists across the board, whether it's a male provider or whether it's a female provider. It's there.
And why is there variations in the way that doctors provide pain medication to women? So why would a doctor perhaps give pain meds to a white woman and not to a black woman?
Well, probably for the assumption that they might consider that the black woman is, you know, drug-seeking behavior.
And what about the point that we picked up with some of the other women stating that, you know, there's this assumption that African-American women are strong and they can push through it and they've got some sort of different stamina than every other woman.
That's the slavery mentality that this country was built off of. And the one thing that is killing black women is the lack of continuity of care when it comes to maternity and reproductive health.
I suppose we do have to look at the sort of town planning aspect of it here. I mean, the decision to close hospitals in areas that need it most, like in Southeast DC or in rural areas, I mean, there is an aspect of institutionalised racism there perhaps as well. But who is it that's making these decisions, such poor decisions for areas of people that are literally, they don't already have care as it is?
That's a really good question.
So what's the role of the policymaker here?
They need to know their constituents. They really need to know what their constituents need. And certainly the most basics of needs are health, water, housing, and that should be, you know, primary focus when somebody wants to run for public office.
One of the other points that I picked up in my research was that doctors feel that it's not just about the healthcare system here. We need to better foster the community around pregnant women so that there's mothers, sisters, friends, neighbours supporting pregnant women through their childbirth and afterwards as well, because women often feel alone in the process. What do you say to the community aspect and fostering better awareness around childbirth?
I think it's important for physicians to kind of involve themselves in the community, whether it be through church-related functions, whether it be through health fairs, whether it be through social media. I think the focus should be more on educating the women. Certainly within the community, there's always church, there's always mosque or whatever religious entities exist.
And I guess, Denise, that's where your role is so vital, because you are adding that extra support to a mother. Obviously, a lot of women can't afford a doula though. What do women need to do individually to sort of try and make their pregnancy and their childbirth and postpartum smoother and perhaps a bit more educated?
It's very helpful to shift the focus of maternity and getting ready for motherhood off of the capitalistic attitude that this country has. New moms don't need a whole birth registry of items, materialism, things, and $800 strollers. They need to keep life really simple and put that money on resources and support. So every woman can afford a doula. There are doulas at community level that do work for free, and there are higher end doulas that get paid very well to do their support services. But the woman has to be willing to see the value in giving that money for that support. And that's something that the Black community is lacking on.
Yeah, that's interesting, because that's something that I came across with one of the women in the film. They did mention that they felt they couldn't get the support from their mother. There was this kind of external experience where there wasn't an emotional bond and they could actually go through the journey together. Do you think that African American women need that service more than any other woman in the society?
African American women need it because of epigenetic inheritance, because we are carrying a legacy of trauma, because we are carrying a legacy of hurt, because we are carrying a legacy that is basically subdued and hidden. And a lot of these emotions, a lot of these feelings come up in birth, in pregnancy. So yes, I think it is very, very helpful for Black women to seek out this support and embrace it for the value that it brings, because it will change the actual story of birth for Black women.
Well, let's hope it does. Thanks very much to both of you for your time.
Thank you.
Thanks to both of our guests. We'll have to leave it there for the time being. It is a difficult issue to discuss and we'd like to hear your thoughts. You can contact us on Facebook and Twitter at TRT World and be part of the conversation. Now, well, that's all the time we have for today on the show. Thanks to our team here in New York, and please join us next time on The Square.